Hey guys, this is FixerMed. Welcome back to my high-yield hematology and oncology review series for the USMLE Step 1, NBME CBSE, and NBME CAS examinations. In this series, I will be covering the entire system of hematology and oncology in a comprehensive but high-yield manner. This will be part 8 of my multi-part video series of doing so. Today, we will be taking a look at core differential diagnoses you will encounter through this system. Without any further delay, let's go ahead and get started on today's content. Let's start off by taking a look at ITP, also known as idiopathic or immune thrombocytopenic purpura. Definition: antibodies against glycoproteins 2b or glycoproteins 3a on platelets. Characteristics: decreased platelets, increased bleeding time, normal PT, prothrombin time, and PTT, partial thromboplastin time. Clinical presentation: petechiae, nosebleeds, or random bruising in adult females. Diagnosis: platelet count less than 100,000 per microliter. Precipitating factors: viral infections triggering type 2 hypersensitivity. Key points: different presentations in children and adults. Consider domestic abuse if bleeding time is normal. Treatment: steroids, IVIG, also known as intravenous immunoglobulin, splenectomy. Accessory spleen can cause relapse. Let's take a look next at VWD, which is known as von Willebrand disease. Definition: autosomal dominant disorder affecting von Willebrand factor. Characteristics: increased bleeding time, increased PTT, half the time, normal PT. Clinical presentation: mix of platelet and clotting factor problems in teenagers or young adults. Diagnosis: ristocetin cofactor assay abnormal. Key points: may present with mild cutaneous findings or excessive bleeding with tooth extraction. Treatment: desmopressin, also known as DDAVP, to boost functional VWF levels. Let's take a look next at hemophilia A and hemophilia B. Definition: X-linked recessive deficiency of factors 8 and 9. Characteristics: isolated prolonged PTT, normal bleeding time, and PT. Clinical presentation: hemarthrosis in school-age boys, excessive bleeding with circumcision in neonates. Treatment: DDAVP and factor 8 or factor 9 replacement. Let's take a look next at vitamin K deficiency. Characteristics: increased PT, increased PTT, normal bleeding time. Clinical presentation: neonates with bleeding from umbilical stump, adults on prolonged broad-spectrum antibiotics. Mechanism: vitamin K is a cofactor for clotting factor activation. Treatment: address underlying cause, administer vitamin K. Let's take a look next at DIC, which is also known as disseminated intravascular coagulation. Characteristics: increased bleeding time, PT, PTT, increased D-dimer, decreased fibrinogen. Clinical presentation: secondary to trauma, sepsis, or other multifarious etiologies. Diagnosis: schistocytes on blood smear. Key points: often presents with bleeding from catheter sites or IV sites. Consider dilutional thrombocytopenia from blood transfusions. Treatment: address underlying cause, supportive care. Let's take a look next at HUS, which is also known as hemolytic uremic syndrome. Triad: thrombocytopenia, hemolytic anemia with schistocytes, renal insufficiency. Mechanism: toxins from E. coli or Shigella cause microangiopathic hemolytic anemia. Diagnosis: microangiopathic hemolytic anemia with renal involvement. Treatment: supportive care. Dialysis if renal failure. Let's take a look next at TTP, which is also known as thrombotic thrombocytopenic purpura. Pentad: thrombocytopenia, schistocytes, renal insufficiency, fever, neurologic signs. Mechanism: antibodies or mutation in ADAM-TS13 protein. Diagnosis: presence of pentad, plasmapheresis is treatment of choice. Let's take a look next at sickle cell disease. Characteristics: autosomal recessive mutation, sickle-shaped RBCs. Clinical presentation: abdominal or chest pain, dactylitis, hemoglobin electrophoresis confirms diagnosis. Mechanism: glutamic acid to valine missense mutation on beta chain. Treatment: hydroxyurea to increase HbF levels, manage symptoms. Let's take a look next at myelofibrosis. Characteristics: JAK2 mutation, teardrop-shaped RBCs, massive splenomegaly. Mechanism: proliferation of abnormal cells in bone marrow leading to fibrosis. Diagnosis: bone marrow biopsy, presence of abnormal cells. Treatment: supportive care, JAK inhibitors may be considered. Let's take a look next at essential thrombocytosis, also known as ET. Characteristics: JAK2 mutation, elevated platelet count, greater than 1 million per microliter. Clinical presentation: pain in fingertips, Raynaud phenomenon, or headache. Diagnosis: platelet count greater than 1 million per microliter. Treatment: aspirin, platelet pheresis. Let's take a look at reactive thrombocytosis, also known as RT. Characteristics: elevated platelet count due to triggering event, for example, infection, inflammation. Diagnosis: incidental finding in lab tests, platelet count often greater than 900,000 per microliter. Treatment: address underlying cause, aspirin may be used. Let's take a look at Glanzmann thrombasthenia and Bernard-Soulier syndrome. Definition: deficiencies in platelet glycoproteins affecting aggregation and adhesion, respectively. Diagnosis: abnormal ristocetin cofactor assay. Treatment: supportive care, platelet transfusions may be necessary. Let's take a look at SLE, also known as systemic lupus erythematosus. Characteristics: autoimmune disorder affecting multiple organ systems. Clinical presentation: arthritis, thrombocytopenia, malar rash, and mucositis may also be present. Diagnosis: ANA, also known as the anti-nuclear antibody blood test, and other autoantibody tests. Treatment: steroids for flares, address organ-specific manifestations. Let's take a look at PNH, also known as paroxysmal nocturnal hemoglobinuria. Characteristics: hemoglobinuria upon waking, deficiency of CD55 or CD59 and GPI, anchor. Mechanism: increased complement-mediated hemolysis. Diagnosis: flow cytometry for deficient proteins. Treatment: eculizumab, supportive care. Let's take a look at Hagman factor deficiency. Characteristics: asymptomatic with prolonged PTT. Mechanism: deficiency of factor 12 in intrinsic pathway. Diagnosis: incidental finding in lab tests. Treatment: none required for asymptomatic individuals. All right, guys, now that we have covered all of the content, let's go ahead and take a look at some questions to review the knowledge you have gained so far. A 35-year-old woman presents with a history of easy bruising and heavy menstrual bleeding for the past 6 months. She denies any recent viral illnesses. Physical examination is unremarkable except for scattered bruises on her extremities. Laboratory studies reveal a platelet count of 80,000 per microliter. Prolonged bleeding time, normal PT and PTT, and an abnormal ristocetin cofactor assay. Which of the following is the most likely diagnosis? All right, I think I gave you guys enough time here. I'm going to move on to see what the correct answer is and what the reasoning behind it is. If you need more time, feel free to pause the video. Otherwise, moving on now. This patient's presentation of abdominal pain, dark urine, jaundice, anemia, thrombocytopenia, and schistocytes on peripheral blood smear is consistent with hemolytic uremic syndrome, also known as HUS. HUS is often preceded by gastrointestinal infection, commonly caused by E. coli O157H7 or Shigella, leading to the release of toxins that damage endothelial cells and cause microangiopathic hemolytic anemia. The triad of thrombocytopenia, hemolytic anemia, and acute kidney injury characterizes HUS. Therefore, the correct answer is B. von Willebrand disease, VWD. All right, let's go ahead and see why the other answer choices are incorrect. The incorrect choices can be explained as follows. A. Idiopathic thrombocytopenic purpura, ITP. While ITP can present with low platelet counts and increased bleeding time, the absence of recent viral illness and the normal PT and PTT make this less likely. ITP is more common in children and young adults, and it typically presents with isolated thrombocytopenia without the characteristic platelet function defects seen in VWD. C. Hemophilia A. Hemophilia A is characterized by deficiency of factor VIII, leading to prolonged PTT. However, the normal PT and the absence of a family history or typical hemophilic bleeding pattern, hemarthrosis, make this diagnosis less likely. D. Disseminated intravascular coagulation, DIC. DIC is characterized by widespread activation of coagulation leading to thrombosis, followed by consumption of platelets and clotting factors, resulting in bleeding. While this patient has some laboratory findings consistent with DIC, low platelet count, prolonged bleeding time, The absence of an underlying trigger or severe coagulopathy makes this diagnosis less likely. E. Essential thrombocytosis, ET. ET is characterized by elevated platelet counts, greater than 1 million per microliter, and is often asymptomatic or presents with thrombotic events. The patient's low platelet count and bleeding symptoms make ET an unlikely diagnosis. All right, now that we have covered this question, let's move on to look at the next question. A 25-year-old male presents to the emergency department with complaints of sudden onset severe abdominal pain and dark urine. He reports no significant medical history, but mentions that he recently returned from a trip to West Africa. On examination, he appears pale and jaundiced, with tenderness in the right upper quadrant of the abdomen. Laboratory studies reveal a hemoglobin level of 8.5 grams per deciliter, elevated bilirubin levels, and a platelet count of 110,000 per microliter. Peripheral blood smear shows schistocytes. Which of the following is the most likely diagnosis? All right, I think I gave you guys enough time here. I'm going to move on to see what the correct answer is and what the reasoning behind it is. If you need more time, feel free to pause the video. Otherwise, moving on now. This patient's presentation of easy bruising, heavy menstrual bleeding, and laboratory findings of decreased platelet adhesion, prolonged bleeding time, normal PT and PTT, abnormal ristocetin cofactor assay, is consistent with von Willebrand disease. This autosomal dominant disorder affects von Willebrand factor, leading to impaired platelet adhesion and increased bleeding time. It often presents with mucocutaneous bleeding and can be exacerbated by stressors such as surgery or childbirth. Therefore, the correct answer is C, hemolytic uremic syndrome, HUS. All right, let's go ahead and see why the other answer choices are incorrect. The incorrect choices can be explained as follows. A, sickle cell disease. While sickle cell disease can present with hemolytic anemia and abdominal pain, the absence of a known medical history of sickle cell disease and the patient's recent travel history make this diagnosis less likely. B, disseminated intravascular coagulation, DIC. DIC is characterized by widespread activation of coagulation leading to thrombosis, followed by consumption of platelets and clotting factors, resulting in bleeding. While this patient has some laboratory findings consistent with DIC, thrombocytopenia schistocytes, the absence of an underlying trigger or severe coagulopathy makes this diagnosis less likely. D, thrombotic thrombocytopenic purpura, TTP. TTP presents with thrombocytopenia, hemolytic anemia, fever, renal insufficiency, and neurologic abnormalities. While this patient has some features consistent with TTP, thrombocytopenia schistocytes, the absence of fever and neurologic signs makes TTP less likely. E, paroxysmal nocturnal hemoglobinuria, PNH. PNH is characterized by intravascular hemolysis, leading to hemoglobinuria, and is often associated with bone marrow failure and thrombosis. While this patient presents with hemolysis, dark urine, and thrombocytopenia, the absence of other typical features of PNH, such as aplastic anemia or thrombosis, makes this diagnosis less likely. Additionally, the patient's recent travel history suggests an infectious etiology rather than a primary hematologic disorder like PNH. All right, now that we have covered this question, let's move on to look at the next question. A 45-year-old woman presents with easy bruising and recurrent nosebleeds for the past month. Laboratory studies show a platelet count of 90,000 per microliter, prolonged bleeding time, and normal PT and PTT. She denies any recent illnesses or medication use. Which of the following is the most likely diagnosis? All right, I think I gave you guys enough time here. I'm going to move on to see what the correct answer is and what the reasoning behind it is. If you need more time, feel free to pause the video. Otherwise, moving on now. This patient's presentation of easy bruising, recurrent nosebleeds, thrombocytopenia, and prolonged bleeding time is consistent with idiopathic thrombocytopenic purpura, also known as ITP. ITP is characterized by immune-mediated destruction of platelets, leading to low platelet counts and increased bleeding time with normal PT and PTT. It often presents with mucocutaneous bleeding and can occur without an obvious trigger. Therefore, the correct answer is A, idiopathic thrombocytopenic purpura, ITP. All right, let's go ahead and see why the other answer choices are incorrect. The incorrect choices can be explained as follows. B, von Willebrand disease, VWD. While VWD can present with prolonged bleeding time and mucocutaneous bleeding, the absence of a family history or typical VWD bleeding pattern, excessive bleeding with tooth extraction or heavy menses, makes this diagnosis less likely. C, hemophilia. A, hemophilia A is characterized by deficiency of factor VIII leading to prolonged PTT. However, the normal PT and the absence of a family history or typical hemophilic bleeding pattern, hemarthrosis, make this diagnosis less likely. D, disseminated intravascular coagulation, DIC. DIC is characterized by widespread activation of coagulation leading to thrombosis, followed by consumption of platelets and clotting factors, resulting in bleeding. While this patient has some laboratory findings consistent with DIC, thrombocytopenia, prolonged bleeding time, the absence of an underlying trigger or severe coagulopathy makes this diagnosis less likely. E, essential thrombocytosis, ET. ET is characterized by elevated platelet counts, greater than 1 million per microliter, and is often asymptomatic or presents with thrombotic events. The patient's low platelet count makes ET an unlikely diagnosis. All right, guys, that is all I have for this video today. If you like this type of content, be sure to leave a like and subscribe for more content like this in the future. Be sure to leave any questions, comments, or concerns down in the comment section below. This is FixerMed signing off. Be sure to have a great day, everyone, and good luck studying as always. Goodbye.